Hi friends, good evening. I'm Dr. Ashutosh Gupta, and let us talk about what is a normal variant in a nuclear scan and a level 1 scan. Okay, so we are usually doing this nuclear scan at something around 12 weeks and 4 days. Right? Why we have chosen this period is this that the anatomy of the baby is like this, that probably all the physiological processes they started to function and they've started to mature, and apart from looking around from the structure, which is basically the nasal bone and the nuchal translucency, we can really look around for a lot of things as a matter of fact, right? So we are trying to do a complete sweep of the baby, and we are trying to invert the pyramid as far as the congenital anomalies to the fetus is concerned, right? So we are doing it at something around 12 weeks 4, 12 weeks 5 days, right? But we have identified that there could be some findings which could be normal variant, right? And therefore, it is very, very important to really make it a point and to tell to the patients in a very crisp and a clear way that this is just a normal variant and we should not get worried about that particular finding, right? So this is like one of the cases that probably we will discuss in these slides, and I'll let you know whether how do we counsel regarding this particular finding. So this is a primary gravida, which we are doing the scan at 12 weeks and 4 days. So nasal bone is 2.7, nuchal translucency is 1.5 millimeters. Both of them are well within the normal range. Ductus venosus, which is normal. We have looked around for the structure, which is also normal, but we are identifying an early sort of a mild TR, right? And this is not a complete, it is not in holosystolic, so it is an early TR. So what we are doing is just we are doing and scanning to the heart. So four chamber, tricuspid, mitral, pulmonary veins, and outflow tracts look good. So the tricuspid regurgitation is a normal finding in less than minus 70 centimeters per second. It can be physiological, pathological, right? And physiological things can be identified. They are usually normal, could be associated with chromosomal abnormalities and structural cardiac defects, right? And what we identified is could be an anemia or an infective etiology could also be there, right? And but the natural course is this, that the mild TR is a normal and it is a benign. It would usually, as the cardiac systems would mature, so the prognosis is very good, right? And so there is hardly anything to get worried about, and this is usually benign. Once it is higher, when the NT is more, then it could be abnormal. We see the echocardiography. So the tricuspid regurgitation, which is less than minus 70 centimeters per second, and which is very early in this stall, okay? So, which we identified to be benign, can be identified in 3 to 4% of the normal euploid fetuses. If the NT is normal, then there is hardly anything to get worried of. If the position of the baby is absolutely great, we can really do the sort of an first evaluation of the cardiac, and then we can really very well differentiate between the left ventricle, right ventricle. We can really look around for the valves. We can definitely directly we can look around for the flow across the tricuspid valve, meaning thereby that the AVSDs and then the outflow tract, LVOT and the crossing of the great vessels can be very well delineated, and therefore the conotruncal malformations and the AVSDs can definitely be identified, right? And we have identified as the cardiac functions that matures, as the compliance of the heart increases, this is going to settle down on its own. So there is hardly anything to get worried about all these things. But if the nuchal translucency it is greater, how much it should be greater? It should be greater than 95th centile for the CRL, meaning thereby that for that CRL, so the nomograms are available. If the NT is greater than 95th centile for the CRL, then probably it could be a sign for a aneuploidies. Aneuploidies could be most commonly could be Down syndrome, and then we can have a 13, 18 also. And then we are doing the same sitting. What we are doing is this, that we are looking for the cardiac evaluation, and then we are looking for the sort of a reversal of the AV with ductus venosus. If it is not there, if the cardiac evaluation at 12 weeks is absolutely great, then there is hardly anything to get worried of. This TR is going to settle on its own as the cardiac functions, as the compliance of the heart comes in, as the cardiac functions that matures and the cardiac muscles gets more compliant. This tricuspid regurgitation is going to settle down on its own. What if we can offer an NIPT for the Down syndrome? Yes, definitely. Yes, definitely, because then that alleviates the anxiety of the mother, because Down syndrome is one of the commonest aneuploidy that probably we're dealing up with. But the nasal bone, and then we look around for the long bones, right? So the long bones, the FL matches to the CRL 0.99, meaning thereby that if you are not dealing with any of the circumstances in which we are having a short long bones, and the nasal bone is absolutely great, so possibility of the Down syndrome or aneuploidy becomes sort of negligible. But then also this non-invasive prenatal testing can be offered, and therefore, but then coming on to this finding of a mild early mid systolic TR less than minus 70 centimeters per second, this is a normal benign. We can identify it to happen in something around 3 to 4% of the fetuses. Only thing is this, that probably we need a follow-up ultrasound, not early but probably at 15-16 weeks, so as to see that probably everything is fine to the baby, right? And no invasive testing is required for that particular finding. If other findings are normal, if the NT is absolutely normal, if there is no reversal with ductus venosus, if we are not identifying a short long bones, if there is no issues regarding the nasal bone, if the cardiac evaluation is absolutely great, then probably no invasive testing is warranted, right? Okay, a follow-up ultrasound at something around 3 weeks or 4 weeks down the line would suffice, right? Thank you very much for your patient listening.